So, very briefly, hopefully everyone knows this sort of stuff. Thoracic spine, 12 ribs, and we know that there's 3 joints within that thoracic spine. We've got the facet joint joining one vertebra to the next, and we've got 2 rib joints. These are the ones that Carly's going to talk about quite a bit. We've got rib joint which we indirectly affect. Pretty hard to palpate that one. If you are palpating it, the person's probably in a lot of trouble anyway. And the costo-transverse joint, which we can... Thanks, mate. How do you press it? All right, and the costo-transverse joint, which obviously we can assess, and Carly will go through that. Well, I hope Carly's going to go through that. She's going to go through that as well. Facet joint, a bit better picture than the last one. I'll talk a little bit about the facet joints with regard to flexion extension, and I'll leave the rotation stuff up to Carly. I think that's quite easily seen visually with regard to the movement capability. So flexion extension, very important. If you remember, flexion extension of a facet joint, when we flex our facet joints or flex our spine, we're opening our facet joints up or into flexion, and when we extend our thoracic cage or any part of our spine, we're going back into extension. So opening and closing, or flexion and extension. Of course, this is a summary. So with regard to the biomechanics, we've got flexion extension, we've got lateral bending, we've got rotation. Now within the thoracic spine, if you go by a very basic rule that the further down the thoracic spine we go, the more flexion extension range we have. Okay? The further down the thoracic spine, the more flexion extension range. So hence, why is that important to keep that in your brains? Because when you are assessing somebody and looking at flexion extension ranges, obviously it's pretty handy to know what is normal. So you don't look at the spine and think, wow, gee, they've got heaps of movement at the lower part of their thoracic spine, but there's none in the mid or upper. Okay? So if you don't know the norm, then you don't know what the abnormal is. With regard to axial rotation, it's the opposite. Okay? The further down the thoracic spine, we get less and less axial rotation. So again, if you're assessing somebody, you're looking at rotation of the spine, you expect to see less down in the lower thoracic spine. That's normal. If it's equal throughout, you know you've got a bit of a problem. All right? What is equal throughout is lateral bending, okay? Except for the last couple of vertebrae. And for those who haven't, I haven't given this before, it's really worthwhile pulling this out and shoving it on your wall. It's a really quick little visual. If you forget or you're late in the day and you're struggling, have a quick look, and it's very easy to show your clientele as well, is that we're looking at the thoracic spine through this region. You can see as we go down the thoracic spine, flexion and extension range increases. With regard to rotation, as we go down the thoracic spine, it decreases. Lateral bending is pretty similar, except for those last couple where it does increase. So that's the normal. So if we understand the normal, we can assess for the abnormal. The term coupling, and I know a few people have gone through this before. I've actually presented this to Andrew about 26, 27 times now, and he can't spell it, let alone understand the concept. But he is a little bit strange. So with regard to coupling, what does coupling mean? Coupling is what happens with regard to a facet joint when it laterally bends and rotates. So in general, when one of your vertebrae side bends to one side, it also laterally rotates to the same side. Okay? So when you side bend to the right, that vertebra in isolation throughout the spine will rotate to the same side. Okay? This is very strong in the cervical spine. It's very strong in the lumbar spine, except for the last couple where it actually side bends and rotates to the opposite side. Okay? And throughout the thoracic spine, in the upper thoracic spine, it's still quite strong, similar to the cervical spine. In the mid, becomes a little bit ambiguous, and in the lower 3 or 4 thoracic spine, thoracic vertebrae, it's incredibly ambiguous. It can side bend and rotate to either side. So again, if you know that that's normal, and you're looking at side bend and rotation, then you should expect to see in the upper thoracic spine, when you side bend one way, you get rotation to the same side. So when you go to treatment strategies, you think, well, I really want to increase the rotation through the thoracic vertebra in the upper segments. If they're struggling to rotate, or you're struggling to come up with a technique to actually increase rotation through some type of pain inhibition or whatever it might be, then you know, well, gee, I can just actually go into some type of lateral bending technique to increase the lateral bending through that vertebra, and I know due to coupling, I'll actually increase the rotation at the same time. All right, so again, it's just knowing what's normal, so then you can add in treatment strategies to have an effect. But of course, as I said, in the lower part of the thoracic spine, the coupling can be all over the place. Okay? Not going too fast? I told you it was going to be quick.
I think I got it that time.
You got it? All right, I'm going to talk about a little bit of flexion extension, and Carly's going to talk about more about rotation. So flexion extension, as I said, pretty basic. We've got our facet joints through the thoracic spine. Okay, I'm looking from behind. We've got this going on, and as soon as we get to, does anyone know what happens when we get to do the thoracolumbar spine? T12, L1. Transitional. Massive transition. The spine, the facet joints from the cervical spine, so it's like this, and we've got this happening, and then we've got this, and we get down to T12, L1, and what happens? Within one vertebra, we get a massive change. So where do you reckon the most degeneration is throughout our spine with regard to facet joints? Yeah, the T12, L1, that transition, either T12 or L1 or even T11, which compensates by taking all the load. So by understanding again where the facet joints sit, you can theorise and make logical why people will get certain pathologies in certain vertebrae. Okay, so I'm bringing up terms that Carly might throw up. So as I said, so you've got an understanding of nomenclature. She doesn't have to stop and go back to fundamentals. So when someone says they have a flexed lesion in their thoracic spine, it means that the joint is stuck in flexion. All right? This can get really, really messes with your head, because they say a flexed lesion is a joint that's found in flexion, and you find it in extension, and then you extend it in your flexors, and the other side flexors, and then you extend to make it all the flexion go away. And when an osteo talks like that, you think, right, give us something, and I throw it at them. So I try to simplify it. When your facet joints, they can flex and they can extend. Now, I don't think any of us here are young enough for that to still occur beautifully. All right, so we get facet joints that get stuck in flexion, we get facet joints that get stuck in extension. Okay? Now we've got someone, beautiful specimen. Andrew, could you pop up for a second? I use Andrew because he's abnormal. So when Andrew goes into flexion, we've got facet joints opening up, right? Going into flexion. Now if Andrew has an extended lesion, which means they're both stuck in extension and they can't flex, then when he goes forward, there's going to be a point which won't open up. All right, it'll be stuck. And you can go back to that little grid that I gave you and think, well, hold on a second, is that normal or abnormal? No, down lower we should actually be getting a lot more flexion than upper, so that must be stuck in extension. So you know now you have to create more flexion through that joint. So what you'll see is nothing, 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 and then a big flexion angle. You might notice Andrew's got he might have a whole heap of compensatory patterns. So, all right, which is unfortunately the way Andrew walks most of the time, but we accept him how he is.
I've looked at it.
Testing that seated or standing?
Both,
Okay.
depending on depending on what they're doing within their normal work or athletic performance, whatever it is, it's best to test, which is pretty obvious, I suppose. If someone's sitting all day long, there's no use testing them in standing because they're not doing it. Most of the day isn't in that standing position. So again, in an extended, if you've got a flex lesion, when someone tries to extend, so it's stuck open, so when he tries to extend backwards, he gets to the point where there'll be one segment that won't extend, so he'll either do what Andrew does, he'll push his pelvis forward to get extension, so he gets massive extension through L5S1. All right? All right, so that's when you've got either side. So you've got both sides, sorry. When you've got both sides stuck in either flexion or extension, it's pretty basic. When you've got one side stuck in flexion or extension, then it starts to get a little bit tricky. But again, if you can understand it, when someone bends forward and you go, oh, look at their increased musculature on one side, I challenge it and say, well, maybe it's just that one of the facet joints or a group of facet joints is either stuck in extension or flexion. Okay? So come over a bit, man. So let's say Andrew is stuck in extension on this left-hand side. Okay. So they're stuck in extension. Okay. So they can't flex.
Do you want me to try and do it?
All right, Andrew's going to try and do it. I'm going to hold this down. So he's going to go into flexion. These ones are opening up. These ones are not. So what happens is he starts to rotate like so. Okay? And unfortunately, Andrew's an extremely bizarre case, and I probably should use someone a little bit more normal. But what happens when it's stuck in extension on this side, you're flexing and you can actually rotate away from that side, so it gives the impression that side comes back further towards you, and it gives the sort of the visual that you've got a larger muscle group on that side. Right? But what's actually happening is it's just not going into flexion. You can sit down, thanks mate.
Thanks.
Right, it's not going into flexion, so it's not opening up. All right? So hence you get that rotation to one side. Same thing in extension. If you've got a joint or a group of joints stuck in flexion or a flex lesion, when they try to extend, if they're trying to extend back, they're all closing down. If I can't close down on my left-hand side, then I've got to extend back like so. So this side's closing down, this side's not. And I'll get that type of pattern. Okay? So that's a few hundred pages in a book in a couple of minutes. But if you can just grasp that basic concept of if they flex and they extend, and as a very common pathology, some get stuck in flexion, some get stuck in extension.